progress.
Good morning, everyone. Welcome back for this, our next installment of our coffee club for ACS CAN. As a program note, you guys probably know by now, those of you that are regulars, ACS CAN is the arm of the American Cancer Society that's the leading not-for-profit, nonpartisan advocacy group where we work together with legislators and policymakers to try and do things that make a difference for our cancer patients. So glad to see all of you have joined us this morning. We're going to veer off a bit in terms of our study of the deeper science of research in cancer last month with my brother Dan, and we were glad to get good feedback about that. We're still continuing our series on really what's optimal whole person care, and we're trying to bring different topics in front of this body of attendees to give you maybe a more full understanding of the care of these complex patients. And as my career's evolved as an oncologist, I've seen a massive shift in the understanding and the science behind palliative care. And so we're glad to have Turner West here as a nationally recognized expert in this, who's lectured on these topics in at regional, state, national levels. His formal title is Associate Vice President, right, Turner?
Yes, sir.
For Health Policy, Director of the Palliative Care Center, for the Palliative Care Leadership Center at Bluegrass Care Navigators. He's well known in these circles and serves on a number of different panels and boards and is heavily credentialed in terms of all these things, but really has a lot of boots on the ground knowledge about some of the issues that we may be wondering about here. So I'm excited about this because this is probably one of the more critical topics that we haven't covered. And, you know, I think as we get into conversations, Turner can expand upon this. It's important that we talk about what it really is versus what the perception is. Because I think there's a disconnect between what we see in the clinics and on the hospital wards and what patients perceive palliative care to be. So every time we get this message out to people like yourselves that are advocates around our community, it's important because we can change the stigma and change some of these misunderstandings. So Turner, we're glad to have you here and thanks for agreeing to join us. Maybe I'll start with that. We've got a variety of folks online here, some of which are advocates for cancer at the legislative level, some of which are legislators. We've got a lot of folks from industry. We've got a lot of folks from the healthcare side, and a lot of people I see here on this list that are actually involved in the clinics and the direct care of patients needing palliative care. Maybe let's just start by level setting your definition as one of the thought leaders here. How do you do your elevator speech when you tell people at a party what you do and what palliative care is all about?
Yeah, well, oftentimes when I tell somebody at a party I work in hospice and palliative care, you know, they quickly say that must be really sad, and then we move on to another conversation as quickly as possible. But first, I do want to thank you for having me here. Thank you to the American Cancer Society's Cancer Action Network and Christy and all the work that has gone on to champion the work, the terrific work that is going on in the oncologic space and their work specifically to advance palliative care. Because they really were a forerunner and a thought leader in how to advance access to specialized palliative care for individuals living with cancer. So it's good to be here. Thank you to all of you who joined us via Zoom. There's got to be fatigue that's going on with staring at one another through a computer. So thank you for your time and attention. So with respect to your question around defining palliative care, if I give you a short answer, it would be that palliative care is specialized medical care for people living with a serious illness, with the focus of palliative care being to reduce the stress and symptoms associated with that serious illness. And so I say that, and I think we can get that, but sometimes I find it helpful to define palliative care vis-a-vis hospice, because oftentimes those two words are used synonymously and for good reason. If you look at the national organizations around hospice and palliative care, they're connected to one another. So you talk about the National Hospice and Palliative Care Organization. If you look at a physician who is board certified in this field, they're board certified in hospice and palliative medicine, and so on. So it's easy to confuse the two, but let's try to disentangle them. And if you can just spare me a 1 minute brief history lesson. I'm going to do the history of hospice care in the United States in 1 minute, and then talk about how palliative care evolved out of limitations in the Medicare hospice benefit. The modern day origins of hospice care date back to the 1950s in England. There was a person by the name of Cicely Saunders who looked at how the dying were being cared for in England and found it to be incredibly maladaptive, that people who were dying were often institutionalized, they were isolated, they weren't told they were dying, And this served a function because no one wanted to be reminded of our own mortality. These were reminders of our own mortality, limitations, the reality that we're going to have to confront frailty and loss of independence, those type of things. And she also recognized that there was more to caring for the dying person than simply the management of pain and other bothersome symptoms. And so she coined the phrase total pain, that there's psychosocial pain and existential pain and practical concerns that all contribute to the suffering of the dying person. Her work, while she's talking there, you have Elizabeth Kubler-Ross here in the United States saying essentially the same thing in the 1970s. What Dame Cicely Saunders was doing in England filters over into Canada and comes down to the United States. And in 1974, you have the establishment of the first hospice in the United States in Connecticut. It's in 1982, after several demonstration projects from what was HCFA at the time would become CMS, that hospice care became a covered benefit in the Medicare program. So when we think about hospice care vis-a-vis palliative care, one big thing to remember is that hospice care is a defined benefit in the Medicare program and in state Medicaid programs, and most commercial insurance products have a hospice benefit that is defined, it is paid for, and we know what we're getting when we elect hospice. And so the eligibility criteria for hospice is that a person has to have a terminal prognosis of 6 months or less to live, and they essentially have to waive insurance coverage for the curative treatment of their terminal condition. So that presents real limitations in practice for many people, that it is prognosis-based and not need-based. And so one way I talk about palliative care is that good palliative care is need-based, not prognosis-based. So for the seriously ill person who needs complex management of pain and bothersome symptoms, who needs skilled goals of care conversations about what's going on with their medical condition, what matters most to them in that particular context, and a plan of care forms out of that. That's what I think about specialist level palliative care being more needs-based than prognosis-based. And so it was really out of, again, limitations of the Medicare hospice benefit that this interdisciplinary type approach you see in hospice care is incredibly beneficial for a person that faces end of life, but it can be beneficial to a much broader population. And so going back to my original definition, that it's specialized medical care for individuals living with a serious illness. Again, not limited by prognosis in the case of hospice care. Again, you can have it alongside curative treatment. So it's a bit broader, but the core elements of interdisciplinary care, responding to the total needs of the person, being driven by what's mattering most to that particular person, is how I think about palliative care. And so I did ramble a little bit, Dr. Flora. So what did I say there that may need further clarity?
I certainly can't be critical of people rambling. That's what I do professionally. No, I think that's great. And I think the point I wanted to call out there, you've nailed, which is number one, it's team-based. It's not provider-driven specifically. We have great palliative care providers, but it's a multidisciplinary team. That's a lot of people involved in social work and counseling and navigation and nutrition. And, it's really approaching the patient from the center of the experience rather than the tumors and the other diseases that they're fighting. The other thing I'm glad you touched on is uncoupling. I've always tried to describe this to my patients as hospice and palliative care are like obstetrics and gynecology, hematology, oncology. The fields overlap in some areas. I can't be a cancer doctor that causes low blood counts and not be able to understand the blood issues. I can't take care of leukemia, which is a blood disease, with chemotherapeutic agents without being a cancer doctor. Same as a gynecologic oncologist. And I think the way that I've seen our palliative care team work really cooperatively with hospice, but separately from, is an important distinction, because a lot of the myths out there, the stigma that I've discussed in my introduction, they're myths that palliative care is only for actively dying people, or that palliative care is equated with hospice care, or the one I hear in the clinic all the time is the sense that the doctor's giving up on me. And so maybe let's transfer that discussion and bring science back into it and talk a little bit about what published randomized trials tell us about the advent and the importance of palliative care. So, there were seminal articles that came out in New England Journal of Medicine almost a decade ago, talking about people with metastatic lung cancer. I'm sure you're familiar with these. Yes. Actually extending life for 2 months for those that got early intervention by palliative care versus those who got chemotherapy and oncologic care alone. There are pancreas cancer trials. There have been 5 to 7 really 5 really good randomized controlled trials and 7 total randomized trials. Maybe you could speak to some of the science behind the impact of making that call to get palliative care involved in the first 8 weeks of a patient's care.
Yeah, thank you for bringing that up, Doctor. It's in the context of oncology where you see the best research demonstrating the impact of a palliative care intervention. And you're correct to draw attention to Jennifer Temmel's study looking at individuals with non-small cell lung cancer. I don't know if you're familiar with Atul Gawande, and he had written a book called Being Mortal. And when he was doing the press, I mean, it was on the New York Times bestseller list for, I think it was years almost that it was on the New York Times bestseller list, but he did all the press. He did the Colbert Report and CBS This Morning, all that sort of stuff. And oftentimes when he was talking about this book, he would reference that particular study that looked at exactly as you described, randomized controlled trial where you had standard oncologic care for one group, standard oncologic care plus a palliative care intervention for the other group. And you saw, as you said, improved survival, less depressive scores, improved quality of life, those type of things. When you look at the research around palliative care, some of it is dependent on setting. So in the hospital setting, you see things like quicker resolution of symptoms, moving individuals to lower cost beds that align more with their goals, preferences, and values. In the community setting, we've seen reductions in the reliance of the individual to rely on the emergency department and hospital to manage their medical conditions. So for many individuals, they stated as a goal, hey, I'd like to not use the hospital. And because of the support of a palliative care team in the community setting, they're more likely to have days at home that matter to them. So you see just generally here, you would see improved quality of life, reduction in pain and symptoms. You would see a more advanced care planning, and hopefully that more advanced care planning would lead to more goal concordant care, or people receiving healthcare that aligns with what matters to them most, given their particular medical conditions. Less caregiver exhaustion is another outcome that's been associated with some palliative care interventions. So depending on setting, depending on what the patient population is like, depending on what the palliative care intervention looks like, you see various outcomes that I think we would want to see.
Yeah, for the audience, I emphasize that point. So what we're saying is, if I, as a cancer doctor, find a randomized controlled clinical trial that improves the survival of a pancreas cancer patient by 10 days, that's enough for FDA approval. It's a $150,000 a year pill. Maybe the average person might live 6 weeks longer, and we applaud at our national conferences because we found this new panacea. But here we are with randomized controlled clinical trials in high proportion of palliative care diseases now that are well published, that have survival advantages, sometimes double or triple that actually save the patient pain, save the patient suffering, and save the system's money. And so these patients are not receiving the standard of care when they're not seeing palliative care specialists. And I think some of that speaks to maybe some myths and maybe some reluctance on the side of the providers to bring these things up, because it is a difficult discussion. The second I mentioned palliative care, the daughter starts to get hives on her chest, and the wife starts to sweat, and it's very, very painful. So when you build these in your own programs, how do you approach the providers? How do you change that discussion? How do you give them the tools to bring these things up and not cause terror in the patients?
Yeah, Dr. Ford, because of some of what you saw in the literature around the impact of strong collaboration between your oncologists and palliative care specialists, the American Society of Clinical Oncology has made recommendations about integrating more palliative care into standard oncology. And I think they talk about it in a couple of different ways, I know that it's helpful to think about it, I think, a couple of different ways. So the field will talk about improving primary palliative care. So that would be the skill set of the oncologist, or you could use any kind of specialist, or any person encountering any clinician encountering a seriously ill person, where we want to elevate their ability to manage pain and symptoms effectively and have those goals of care conversations, or breaking bad news, any kind of difficult conversation, that you have the skill set to do that well. We think about that as being enhancing the primary palliative skills of the workforce. And then there's secondary or specialist level palliative care, which are those who do palliative care, who interact with complex, seriously ill persons on a daily basis and are managing complex pain and symptoms and are having really difficult goals of care conversations. And so, I think that is those are two things that the field has been pushing. How do we get more specialists, and how do we increase the skill set of those providing the care to the seriously ill person on a day-to-day basis? So a lot of it has come through to your initial question around peer-to-peer education. The clinician who's always had reservations about palliative care, that you have that one success story where they know that patient was served well by the palliative care team. And I think it's just a lot of kind of education and recurring education. I think the work of the American Cancer Society, the work of ASCO, the champions within oncology who see the impact of this and can educate their peers and colleagues on it is what is most meaningful than simply me saying it or something like that,
Yeah, well, so I'm glad you brought up the guidelines, because we like to say we're guideline based. The guidelines that he's discussing aren't new. This was 2017. And ASCO came out and said that any patient, inpatient or outpatient with advanced cancer, should receive early palliative care within 8 weeks of diagnosis. And I would say, again, we have some palliative care folks on here. If you guys can type in the chat questions or comments or things in your own experience, I'll bring this up during our discussion. I bet here we're probably less than 20%. And so some of the things I've challenged our own team members here, and we've got a few of them on here that run our disease management teams. We've got some of our really good process improvement people. They know that I sort of bang the drum that you can't rise to the level of your goals, you fall to the level of your processes. And so we're really trying to hardwire this. We're trying to build it in through some of our disease teams so that there's an automatic trigger, either a best practice advisory or an automatic generated consult when you have a patient with advanced pancreas cancer or advanced lung cancer. And I don't know that we're quite there yet. I think we had a couple great months when we all concentrated on it, and then the numbers fell off again when we didn't shine the light on it. So I guess it's one of those things that we can aspire to be better at, but this is guideline-based, evidence-based care based upon randomized controlled trials, and it should be pursued as fervently as we do chemo trials. And so I'm glad you're talking about that. Maybe let's make it a bit more personal so we can get wonky talking about the ENABLE trial or the TEML trial. How about how it's affected individual patients? So I'm going to ask you a personal question, because I read in your bio that you have you've a master's in theology, and I wonder if that guides any of the things that you do. But certainly this hits a more personal thing than an EGFR receptor on the outside of a lung cancer cell, right? We're talking about human beings with fears, with trepidation, with anxiety, with sleeplessness, with all sorts of other issues that are weighing on their minds. How do your folks build that into the discussions, both spiritual, emotional, because it's not just the medical stuff. We're pretty good at that.
Right. Yeah. I think so. I came to, we were a hospice of the Bluegrass sort of right out of grad school. So that was 15 years ago when I joined the organization. I thought I was going to stay for 6 weeks, 6 months. I just needed a job out of graduate school. I wanted to coach basketball. I thought that's what I was going to do. And quickly found the organization and the work we were trying to do incredibly compelling and meaningful and worthwhile. And I really kind of cut my teeth on healthcare in the hospice world. So I watched interdisciplinary care every single day. I would talk to caregivers, talk to patients. I would be in our interdisciplinary team meetings, and you would hear time and time again the complexity. You would get a sense for the suffering of the individual, the impact on the family, how multifaceted that suffering could be, and the variety of ways in which just the variation in what's important to a person when they're facing end of life. It was about 8 years ago I got involved in palliative care and saw how we were trying to take that model to a broader patient population. And I'll just tell this story briefly. And so I remember we had a clinic. We had a palliative care clinic. So we had two buildings that were really close to one another. I would always walk between the two buildings because it was short, maybe a 1/10 of a mile. It's one of those days, it's like 100 degrees, humidity. If I make that walk, I'm going to be just drenched. And so I decided I'm going to drive over there. And the parking lot's full. And so I go over by our clinic and I just noticed there's this big pickup truck and the doors open on the passenger side. And I just see a guy who looked about like me standing right by the door. And so I right by the passenger door. So I park and I get out. And I couldn't really tell what he was doing. I look and there's just this emaciated woman who's throwing up all over this hot and all over the concrete. It looked like the truest form of suffering. And I thought about first of all, there was a nonchalance to the son, who I'm assuming he was the son. And it's like, how hard has it been for him that he can see something like this and it's occurring, so frequently that this is something that's not, that he can seem so nonchalant. And two, like, what does 5 minutes look like, when you're out there at that traffic light on Harrodsburg Road and it's hot in the car, just the truest form of suffering. And I kept thinking to myself, this person had to get out of their house, they had to come here to the clinic, they've got this complex pain and this complex pain, these bothersome symptoms that are causing this type of nausea. And so it's really motivated me to think about how do we do a better job caring for a person in that situation. So I think about that on the physical component, but there is just something about the interdisciplinary composition of hospice and palliative care teams. You see the psychosocial impact, about the practical needs that a person feels. I mean, you've seen the research. What's most important to people as they get older? It's retaining independence. They're more afraid of losing independence than they are of pain and symptoms or of dying. You think about the impact there, the existential. I mean, over and over again, I've seen where you have a person's faith that serves them quite well at end of life or when they're diagnosed with a serious illness or cancer diagnosis, and sometimes it can not serve them particularly well and cause a lot of suffering and the need for reconciliation and healing and all those sorts of things. So I think when a person gets diagnosed, I would imagine cancer or a serious illness or a terminal illness, it's incredibly complex. So having that interdisciplinary team to support one another, respond expertly, collaboratively for that person and family is just critical. And it kept me in the field for sure. Oh, and I think you've muted yourself, Doctor.
Thank you. It's been really instructive for me over the course of maybe the last 3 or 4 years as we've seen our own palliative care program really blossoming and adding staff and adding more and more providers and more nurse practitioners and more social workers to see the deep impact that they have, because they make time. As a clinical oncologist here, I know my partners are trying as hard as they possibly can to keep people safe, to keep people whole and work on this stuff, but really challenging to do that well when you have 24 patients a day. And they don't see 24 patients a day because they wish to. They do it because that's 24 people that must be seen to be safe. And so I've been gratified to have our palliative care center next door to us on our second floor, where we can just walk down and grab one of the docs and introduce them to a patient. And you almost overcome those barriers the moment they find out that they can continue to provide aggressive care.
Yeah.
So if I involve palliative care in my patients' lives, you guys are going to help us with symptom control, anxiety, depression, sleeplessness, constipation, nausea, diarrhea, whatever it is. You spend time working on that review of systems top to bottom.
Yeah.
And it actually liberates the oncologist because I can worry about the big ticket items, terror, where are you in your disease? What are our next treatment options if you've had a bad CT scan? And I can really focus my energies on the things that I do best, recognizing that someone else is going to pick up the slack when I didn't have an extra 45 minutes to discuss advanced directives or to discuss what the patient's most anxious about. And I love when the notes come back from your teams and they've just categorically listed all of the things I wished I had time to get to. And so that's where the real interdisciplinary benefits come, is that we are working in concert with one another in parallel tracks to make sure that we're caring for everything. So
yeah, and I would imagine if I were an oncologist, obviously I'm not, but talking to a person who has cancer that is more advanced, about knowing that hospice is not necessarily, they're going to strike terror in them, be a non-starter, but know that they could use that extra layer of support and expertise that an interdisciplinary team that focuses on those issues could provide. And so to be able to talk about palliative care that can complement, provide an extra layer of support, more people to attend to quality of life type issues would be incredibly helpful.
We tweak the system a little bit. I describe the service before I give it a name. Yeah. I'm like, listen, I want to send you to this symptom control clinic, and these are the things that they're going to do. They're going to spend 2 hours with you working on your pain control and your nausea. They may see you weekly when I see you every 3 weeks. Does that sound good to you? And they're like, yes. I'm like, well, this is our palliative care clinic. You passed it when you got off the elevator. Yeah. And they're like, just because of the word is so we're working on that internally as well. And I'm really proud of this team. These guys are doing amazing work every day. And my patients come back to me, and it's a universal satisfaction. I'm so glad that I met Dr. Trice. I'm so glad that I had time to spend with Dr. Bokelman, our two people that are embedded in our building. But the patients are changed when they get back. They feel relief. So let's talk about inpatient stuff, because it's a little different vibe there, right? So palliative care goes inpatient and outpatient, and we're working on home-based care as well, I should say, and that's an important component. How do you deal with the inpatient folks? Because a lot of those guys are MICU discussions and extubations and suspensions of care, and it's a whole different level of emotion.
Yeah, and it was important when I was boring everyone to tears with my history of hospice and the emergence of palliative care. Palliative care did start in the hospitals primarily, because it was the hospitals that saw the potential positive impact in a number of ways in their settings. Hospital-based palliative care, many times we're getting people referred in our so it operates like a consultation where and again there is some variation there. Many times these are individuals who should have been on hospice a month ago, and so we're getting palliative referrals because they may not want to hear about hospice. The referral, the hospitalist doesn't want to bring up hospice, the family doesn't want to hear it, so we get a palliative care consult. I think some of the things that we see in terms of the benefit of for patients who are hospitalized is that a resolution of symptoms. You see that very quickly, and we've tried. That's one of those measures that we're going to track over time. Sometimes our palliative care consultations lead as a bridge to hospice conversation. The hospitalist doesn't feel that they have the confidence to have that conversation well, and so they'll bring the palliative care team in to bring up the Medicare hospice or the hospice benefit, what that means, have those goals, and the goals of care conversation is also I think that's our number one reason for a referral in the inpatient setting is goals of care conversation. So you can think about how, if you're not trained well on that, what a skill that truly is, to be able to sit and have that conversation with the patient and family. So, and I'm not sure I got at your question, but
no, I just think the power of this is that your teams are willing and able and trained to go into the depths of the caves with the patients, the stuff that they're so scared to talk about, the stuff that nobody else teases out. And, I aspire to that as an oncologist, and I try hard. I had one of those conversations yesterday. It was about an hour and a half long, and just heart-wrenching, but critical that it's me. It was a patient of mine I've had since 2005, which is obviously pretty rare for a cancer doctor. We either discharge people because they're cured, or we lose them because they weren't. And this is one of my longest patients. And she survived CLL for 15 years and is dying about 8 weeks after a lung cancer diagnosis. And it was just, I didn't even have time to get you guys involved. She never left the hospital, really, in and out. And I thought we could have done such a better job, because this poor woman that I loved is dying a terribly miserable death, a death by 1,000 cuts, 8 weeks consecutively worse. And we couldn't get anything fixed in time. So I credit to your teams, and I hope you're taking care of your people, because it is a high burnout specialty. And, whereas oncology, there might be one oncologist for every 150 cancer patients, there's one palliative care expert for maybe 1,500 patients. And yet they still find an hour and a half to spend with the patient. So it's awesome.
You correctly point out. I mean, one of the things that, and this has been borne out by a number of surveys of people who are living with serious illness, that they want is time with their healthcare professionals, and the palliative care teams do carve out that kind of time that is so precious, as you point out, for many of our clinicians. I do think that one of the things that is nice to support and mitigate the likelihood of burnout in the palliative space is that interdisciplinary cohesion. Those teams really bond and are there for one another.
Maybe looking forward, how do you see this field evolving? We in oncology are starting to talk about chemotherapy at home or symptom control at home. All of our remote monitors can take my pulse and my EKG and my oxygen levels. And are you guys starting to see this moving more from outpatient and hospital-based care to really getting into people's caves?
Yeah, absolutely. While it started in the hospital, palliative care started in the hospital, hospital-based palliative care by definition is somewhat reactionary. So there was a crisis or something that sent the person into the hospital, and generally that's the only place that palliative care is accessible. I've got a friend and colleague of mine, Martha Twaddle, who's a physician in Chicago, who says about this, that people shouldn't have to suffer first to earn our type of care. So there's been a great move in the palliative space to move into the community space, specifically to kind of go from the hospital to the clinic and to nursing homes and to patients' homes to support them there, that we could do a lot to mitigate suffering, crises for the individual, and reduce the likelihood that they have to travel to the emergency department or go back into the hospital, because for so many individuals, what they say is, I just want to be at home and I don't want to go back to the hospital, that sort of thing. This is where we run into a world where there is what I would call clinical and financial misalignment. So it's very difficult for teams to do this in a financially sustainable way, given the lack of a palliative care benefit. Consequently, these programs are oftentimes funded in a fee-for-service type environment. And so you add windshield time, patient complexity, an interdisciplinary approach, all those things. Fee-for-service is no friend of doing interdisciplinary community-based palliative care. And so the field has been targeting those entities bearing financial risk, Medicare Advantage plans, Medicaid managed care companies, accountable care organizations, that sort of thing, to say in those spaces, we feel like there could be clinical and financial alignment where this is the right kind of support for the seriously ill person in the right setting. And financially, you would do well if they are not utilizing the emergency department, if you could see a reduction in emergency department utilization or hospital days, that type of thing. So the field is both wanting to get out there and trying to figure out how to do it in a scalable and financially sustainable way.
Yeah, it's a real disconnect right now between incentives for providers and physicians and goals of care. And yeah, you've nailed it. And we're dealing with that on a global level and more locally here, as we want to move towards a more research-based institution and a more holistic approach to patients' care with these large teams of navigation and survivorship and stuff. And right now the incentives are not aligned. Yeah. It's a struggle. It's a struggle. Yeah. So I do, as a physician executive, I can tell you the return on investment is very, very high if you can prevent recurrent hospitalizations in these patients. Yeah. Like you said, keeping people out of the ER, reducing your readmission rates, reducing the number of people that are unnecessarily ventilated in the ICU in the last 30 days of their life, when that's not what they would have wished had they had that conversation with folks. So yeah. I do think there's actually a business case for those of you that are on the line that are looking at dollars and cents or looking at legislative priorities. Yeah. This is cost-effective care that adds to the patient's life and survival. It's that triple aim, so it's worthy. So how about 5 years down the road? Where do you see your life? Where do you see your care of patients from your center? And what's your dream goal? As you go around advocating around the country for best practices, you're one of the people who designs them. So where do you take this if resources were not a limitation? Yeah, well, I would love a world 5 years from now where it feels like there is a financially sustainable path for many not all, but with some organization, there is a precedent out there for a financially sustainable path to provide scalable access to high quality community-based palliative care. And so that could take a number of forms. You could see really strong partnerships between palliative care, community-based palliative care providers and health plans. There could be precedent for that, not in the private equity space where you have some of the examples of that, but it's certainly not something that's going to be true for every community. You could see it take the form of a benefit. So some states like California has a palliative care benefit in their Medi-Cal, that's their Medicaid managed care program. And so we haven't seen outcomes associated with that since that piece of legislation has been passed, but maybe that will be a model for other states to adopt. There's also models coming out of CMS's Innovation Center that are kind of focused on the seriously ill population. And so the extent to which some of those models may be scaled, give some sense of optimism. But I think that's what is important to me. I would like for a seriously ill person who wants the support of a palliative care team to be able to access it, whether they're in Northern Kentucky, in Lexington, in Missouri, Southeastern Kentucky, wherever, that somebody has that as an option. And right now, the only option for that in a reliable, predictable way is if somebody elects hospice care. And the reason hospice care is readily accessible is that it's a benefit in the Medicare program and it's funded pretty well. So you don't have a shortage of on the supply side of providers. Yeah, that's kind of with what Christy Young does and what Miranda Sloan does, and a lot of the legislative advocates that tune in for these calls. hospice benefit is why people have access to hospice. There's no equivalent for you guys, and it's still RVU based, and it's really it's discouraging use. So, yeah, because these are not profitable cases for a system to see. They're just, it's the right thing to do. I know we're running short on time. I would make a plug. I think you brought up something that's near dear to my own heart. So I'm a student still. And for any of you who didn't recognize the name that he dropped, Atul Gawande, the book that he mentioned is called Being Mortal. It is probably one of the most influential books I've ever read. I love that guy. I think he's one of the clearest thinkers in healthcare right now. I read an article from him in the New Yorker called The Cheesecake Factory Approach, 10 years ago, and I started reading everything he wrote. It's a big part of how I do my own job now, is trying to think like Dr. Gawande. But if you guys haven't read it or listened to it, he's all over the place. He's a really, really inspiring person, but he deconstructed everything that we think we know about what our patients want and what dying is really about and what severe disabling diseases can do to people. And I would encourage you to pick it up or listen to it if you don't have time to read it. It's a compelling vision. So.
Yeah, and there's and they made a short PBS documentary that you can watch if you're like me and too lazy to, or don't have the mental energy to read anymore. So
yeah, well, it's on my bookshelf behind. So if there's any staff members here, the book is sitting behind me. You're welcome to borrow it too. But I think it really speaks to all the things that we've talked about, putting the patients in the center of the conversation, putting ourselves out there and being willing to hurt with them and live in their caves. And then also asking them what's important to them. And I think we can all aspire to that. Everybody in here who touches patients, I've got lots of people that are nurses in our system. And the more people who are aware that you exist, the more people that know that we have this service right down the hallway, the more people we can save from these things. And it's been instructive for me to talk to you. It just affirms sort of the fire in my belly about pushing our teams to try and build this in and truly integrate this service instead of just having it be an add-on. So I thank you all for attending. We're running out of time. We're at 9:37 and I've gone over again, not surprisingly. I told you I'm chatty, but I do appreciate you joining us, Turner, and his contacts will be put in the thread. Some of these things we're adding links, and thank you. It looks like Chelsea added the book is $10 on Amazon, and we'll be back with you in the next month for our next installment, and we appreciate your support. And if there are comments or questions, leave them in the chat and I'll answer them after the program. Thank you all, and we'll log off for now.
Thank you.